Now, the next talk will be by Dr. Mathew KURIAN. He'll be talking about dysphotopsias, causes, prevention, and management. Dr. Mathew KURIAN doesn't need an introduction. He's a very senior cataract surgeon and the medical superintendent at Chaitanya Eye Hospital, Palarivata.
Thank you to AIOC and Sony for this opportunity. So, dysphotopsias are defined as undesirable subjective photic phenomena associated with otherwise uncomplicated cataract surgery. And they can be classified as positive, which is visible streaks, arcs, or flashes or starbursts, and a negative dysphotopsia, which is typically a temporal dark shadow. Then, of course, we have the diffractive optic dysphotopsias, which are halos, rings, or spider webs from point sources of light associated with the diffractive optics of multifocal IOLs. The incidence is unfortunately pretty high, and it is classified as the most common cause of dissatisfaction after routine cataract surgery, up to 50% in one of the articles by Tester, and between 15 to 20% in the other articles. And it is estimated that approximately 750,000 patients yearly present with negative dysphotopsia, which is chronic. The Advisory Committee on Patient-Reported Outcome Measures for Premium IOLs has described that diffractive dysphotopsia affects up to 6% of multifocal IOLs, and this causes this requires exchange of the IOLs. And IOL exchange, which was reported in the JCRS article in 22, talks about 64 eyes of 46 patients, and out of those IOLs that had been exchanged, 83% had diffractive optic dysphotopsias, reduced quality of vision, night vision difficulties. Some were post-YAG refractive laser and post-YAG capsulotomy. All improved symptomatically, and there was no loss of corrected visual acuity. Dysphotopsias are easily measured in terms of a questionnaire, and one of the best questionnaires that I have come across is the Quality of Vision Questionnaire, which was published out of Australia, and this looks at glare, halos, starbursts, hazy vision, blurred vision, distortions, double vision, fluctuating vision, focusing difficulties, and depth perception issues. And the individual scores these based on the frequency, the severity, and the bothersomness on a Likert scale of 0 to 3. And the total is then converted, and this is a validated, rash-validated questionnaire. So if you look at dysphotopsias in the general population, we can have positive dysphotopsias and negative dysphotopsias. There is a clear correlation between the optic lab and clinic findings in positive dysphotopsias, whereas negative dysphotopsias have a poor correlation. Positive dysphotopsia is directly related to the square edge of the IOL design and the optic material, and negative dysphotopsias may be induced by any in-the-bag IOL, irrespective of the material, design, or index of refraction. In positive dysphotopsia, the position of the lens is not a factor, whereas in negative dysphotopsias, the IOL position is the key factor. Negative dysphotopsias can be measured in terms of visual functions on Goldmann perimetry, whereas only patient-reported outcomes is possible with positive dysphotopsias. There is no CNS component, so in positive dysphotopsia, whereas the CNS component and adjustment to that is quite prominent in negative dysphotopsias. So positive dysphotopsias, the root cause was described in the 1990s by Holade et al., and ray tracing analysis of the edge was determined to be the cause. Internal reflections from the square edge was also described by 2001 and 2003. Negative dysphotopsias, on the other hand, are a temporal dark crescent, which was first described by Davidson. Holliday found that it was the IOL edge and the IOL material, along with the depth of the lens inside the gap between the iris and the IOL material. Maskett described that this was a feature of in-the-bag IOLs, while Erie called this as the illumination gap. It is simulated by a temporal peripheral light source, and it may be blocked by just keeping your hand on the side, which will block the light from the extreme temporal sources and prevent the light from entering the gap between the iris and the IOL surface and the nasal edge. Symptoms are worse when the pupil is constricted and better when dilated, and it is associated with anatomically perfect surgeries quite often. A small photic pupil and a high positive angle kappa are associated features. Higher dioptric power IOLs, negative aspheric optics, haptic orientation do not have any association with this. More common for some reason in females and in the left eye, and the symptoms may be uniocular despite similar anatomy. This is the edge gap that was shown, and it can be measured by Goldman perimetry, as in this article out of Maastricht University. The negative dysphotopsia can be prevented or relieved when the reverse optic capture is performed. It is reported to be successful in secondary reverse optic capture with an IOL exchange back to sulcus, resulted in successful outcomes in 7 out of 8 patients, as a piggyback IOL in 8 out of 11 patients, and IOL exchange with bag in the bag does not relieve negative dysphotopsia. And primarily, if it is performed, in the contralateral eye of an individual with negative dysphotopsia, reverse optic capture is almost 100% successful. So how does reverse optic capture work? Typically with multifocal multi-piece IOLs, but it also works pretty well with monofocal IOLs. And after the lens haptics are delivered into the bag, the trailing haptic is being dialed into the bag here. The optic edge is prolapsed anteriorly over the rhexis margin, and then using a second instrument by manual technique, both the optics are both edges of the optics are buttonholed through the rhexis. The side effects of this is obviously earlier onset of posterior capsule opacity, and if the haptics are fairly thick, you can have iris chafing, which would cause secondary glaucoma as well. Specific anti-dysphotopic IOLs are present and are FDA approved currently. This is a video of the Femtis IOL. It's a hydrophilic lens, sort of like a plate haptic design, with the IOL being delivered into the bag. It has got flanges coming off the anterior surface of the optic, and these can be, once the trailing haptic is placed into the bag, the flanges are then anteriorized and capture the rhexis margin between the anterior and posterior portions of the lens. In individuals with chronic non-resolving negative dysphotopsias, which is disrupting to their lifestyles, IOL explant is the only option, and using good quality oculoviscoelastic devices to protect the endothelium as well as the posterior capsule, the lens can be bisected or cut at least 50%, and then it can be rotated out of the bag. Post-YAG dysphotopsia, this is an interesting case. I'll finish with this one. It's a 47-year-old male post IOL in May of last year. By November, he had glare, and in November, the YAG capsulotomy was done, immediately post which he complained of glare and starburst in all directions. Treatment with brimonidine did not work, and 3 months later, post-YAG, this was the condition where this extensive amount of pearl formation on the edge of the YAG opening was causing the glare in all directions, and the YAG opening was enlarged. following which there were these small tags which were superior and inferior and one floating tag in the middle, and the patient was complaining of a horizontal streak of light which was successfully managed after treating those little fragments with further YAG. So I leave you with this management algorithm: unwanted optical images. Dark temporal crescent is negative dysphotopsia. If it is temporary, we can ignore it. If it's persistent, you need to do reverse optic capture or IOL exchange. Positive dysphotopsias, improvement with pharmacological meiotic therapy. We can leave it alone. If it is not effective, we need to exchange. And in the diffractive multifocal IOL, again, if it is settling down with neuroadaptation, leave it alone. If it is not settling at the end of 3 months, we need to exchange that as well. Thank you for your attention.
Thank you, Dr. Mathew, for that very illustrative and explanatory talk on the dysphotopsias. The YAG one was very interesting, especially the tag which was in, and also the update about the newer IOL, which is mainly intended to prevent